Hello, my name is Pedro Kurtz. I'm speaking from Rio de Janeiro. I'd like to thank the organizing committee for the invitation to this conference. I will discuss challenges of subarachnoid hemorrhage management in developing countries. I have no conflict of interest. The content of the presentation will include epidemiological and outcome data, hospital case volume. We'll briefly discuss aneurysm occlusion strategies and timing, and the potential role of tranexamic acid. So this is an example of a analysis of an international cohort, including many studies, more than 14,000 patients, showing that 23% of patients were poor grade or had WFNS 4 and 5, altered mental status, and mortality overall was 13% and poor outcome in 1/4 of the patients. This example highlights the few studies in patients from South America and Central America in most of the large cohort data published in the literature. This is another example of an important issue, which is case fatality over time. Authors demonstrate that in the last 40 years, there was a reduction of 17% in mortality of SAH patients. And 2 studies only from Chile and Martinique, again highlighting the lack of data from these regions. A few national cohorts and single center large cohorts. This is from Australia and New Zealand, more than 11,000 patients, more than half poor grade with 29% mortality. And although there was a reduction in mortality in the initial years, after that, mortality remained stable over the last 10 years. These are 2 studies from one single center cohort from New York City, the Columbia University SHOP database, demonstrating a mortality after 12 months of 22% and improvement in mortality, especially in the poor grade patients. A couple of small cohorts from South America. This is from Chile and Argentina, but few patients in each cohort, demonstrating high case fatality rates of 47% in Argentina and 40% in Chile. So due to the lack of evidence, we retrospectively analyzed a prospective study of ICU patients and included 997 cases of SAH. In this cohort, we have admission characteristics, comorbidities, clinical severity, and organ dysfunction data. Although we don't have neuro-specific data, we could estimate poor grade patients, and we demonstrated a hospital mortality of 34%. So one of the major challenges of SAH management in developing countries is the lack of high quality data from large cohorts. We don't have regional data or temporal trends, and we don't have neurologic specific presentation data or functional outcome from large cohorts. The other issue we're going to discuss is hospital case volume. In this example, there was a reduction in case fatality with the higher volume of patients treated in the institutions, both clipping and those that underwent coiling. This has been reproduced in different countries and different centers in the literature. It's important to know, to highlight that the threshold of case volume is still controversial, and the effect was not found in cohorts from Brazil and Australia, for example. This is another study published last year showing there's high variation between center and between countries, even when you analyze Europe and North America. And this is probably not just due to case volume, but also other issues related probably to resources and diagnostic and treatment protocols. So a second major challenge is that in spite of a unified public healthcare system in Brazil and major private hospital networks, referencing to specialized centers usually insufficient, and we do not have data on the effect of case volume or resource-associated variables. The third issue is aneurysm treatment. This is the ISET data looking at long-term follow-up. And what it shows is that endovascular treatment remains beneficial after 4 years when compared to clipping. But conclusions from Cochrane Library systematic review is that we don't yet have reliable data to affirm to all patients that coiling is better, especially if they are in a poor clinical condition. Also, when you looked at the ISAT data, patients that were submitted to surgical clipping were treated with delays, and that may have impacted their outcome. So we looked at our cohort, 2-center observational study in Brazil, 2 studies that receive patients and have neurosurgery on call. We showed that patients arrive late to the centers, many of them after 4 days and many of them after 8 days, with impact in mortality. This data is still being analyzed. So another challenge is that frequently patients are transferred late to reference centers, and also endovascular procedure remains very expensive. For example, in Brazil, when you compare it to surgical clipping, it's 4 to 6 times the cost in the public system. So the 4th issue we'll discuss is the use of tranexamic acid, and if this is an option in resource-limited countries where pre-transfer and treatment is delayed. This is also data from last year, published last year, showing that mortality, in-hospital mortality, after adjustment for other factor, tranexamic acid was beneficial and reduced rebleeding in these patients. However, a Cochrane review did not confirm that this effect has been reproduced in various studies, so it's still a debatable, the application of tranexamic acid. We also looked in our cohort in a single center of 145 patients, and we are comparing patients that did not receive tranexamic acid, received low dose and high dose. This was non-randomized data, and we saw important differences in mortality, and we're still analyzing this to try to give some data on tranexamic acid. So another challenge for the use of tranexamic acid in this setting is that we don't have data in the context of resource-limited settings and countries with common delays to occlusion treatment. So one of the solutions that we started a few months ago, it's still non-randomized data, but we designed a observational study of various centers in Latin America. This include Brazil, South American countries, and Central American countries. In the first 2 months of inclusion, before the pandemic started, we included 224 patients, and we believe we will be able to include between 1,000 and 2,000 patients in the next year. And we hope to, with detailed data collection from these centers, we hope to clarify at least some outcome data, practices, and data related to resources available in different regions and different countries, and what the impact of these aspects are in SAH outcomes. Thank you.